dear chairperson, madam delegates. The present study is inspired by dentistry.
Okay, we will
The
note
idea
down
came
note
to
on the
me
time.
when I was getting my teeth scan done by CBCT DCG. The cone beam computed tomography dedicated to dentistry. Persistent epiphora with patent syringing is a diagnostic dilemma. Various modalities are available to investigate such cases, but none of them uncover the exact pathology. With this background, we designed this study to compare CBCT DCG with conventional DCG and to evaluate the role of CBCT DCG in patients of persistent epiphora with patent syringing. 198 eyes were randomly divided into two groups after taking informed consent, while in one group, dye was injected in inferior canaliculus. In the other group, dye was instilled into conjunctival cul-de-sac. I repeat, dye was instilled into conjunctival cul-de-sac, and the scan was taken after 3 minutes and, if needed, after 15 and 30 minutes. This is the CBCT machine. The patients remain seated comfortably, blinks normally, the dye is instilled in conjunctival cul-de-sac, and the machine takes 13 seconds to complete the scanning. The CBCT images were further classified into three groups. Number one, patent group, where the dye was visualized in inferior matters after 3 minutes. The delayed patency group, where the dye was visualized after 15 or 30 minutes. And the mechanical obstruction group, where the dye was not visualized even after 30 minutes. And in conventional group, there is patent and non-patent. All the images were analyzed by me and the dental radiologist. As with any CBCT imaging, the CBCT provides coronal sections, sagittal sections, axial section, and the reconstructed 3D view. Here is the coronal sections at different level of same patient, showing the flow of dye through nasolacrimal duct, and these are the 3D images viewed from different angles. You can see the canaliculi, common canaliculus, sac, nasolacrimal duct, and even the intraosseous part of the nasolacrimal duct after skimming. The low percentage of patent patients in CBCT group is because of the delayed patency patients. A patient of persistent epiphora with patent syringing, after 3 minutes, dye is visualized only in lacrimal sac area, while after 30 minutes, dye was visualized in inferior matters with gross pooling of dye in lower part of the nasolacrimal duct, indicating the presence of stricture at lower down area. A patient, both sides operated for DCR. Here the first dye traveled up to the level of obstruction, and then it started trickling through the anastomosis into middle meatus. In the last image, you can trace the path taken by dye to reach the nasal antrum. CBCT DCG can be easily done in children without the need of any anesthesia or sedation. We have done in 3-year-old baby. Here is a patient, mucocele on right side. Please focus on left side. Left side had persistent epiphora. We did the conventional DCG and it revealed that it is patent. We called the patient next day. We did the CBCT DCG and see, after 30 minutes, the dye has traveled only up to the upper part of nasolacrimal duct. And then we injected the dye. and it has gone into the inferior meatus. This is the difference between the conventional and the CBCT DCG. CBCT DCG is purely physiological. The anatomical details provided by CBCT DCG and the cost make it superior to scintigraphy, though both tests are physiological. And back to our original patient. In this patient, CBCT DCG revealed kinking at the junction of nasolacrimal duct and the sac, and that was the responsible for the persistent epiphora, which could be easily negotiated by syringing. Hence, I can say it is 100% physiological, new technique, non-invasive, cheap, gives very good anatomical details, and it is very helpful in cases of persistent epiphora with patent syringing. Thank you.